hoje a gente tem a presença do professor Vijay Bhoj. O professor Vijay Bhoj, ele é professor assistente do Departamento de Patologia e Medicina Transfusional da Universidade da Pensilvânia, Unicamp. Vijay, it's a great pleasure having you with us today. And Professor Bhoj will discuss with us the promise and challenges of repurposing CAR T cells to treat antibody-mediated disease. A promessa e os desafios do redirecionamento de células CAR T para tratar doenças mediadas por anticorpos. Vijay, it's a great pleasure having you here, so you have the time that you want, and we will have students and professors here from our university, okay?
Thank you, Margaret. Thank you so much for the invitation and introduction. It's really a pleasure to chat with all of you. And Margaret told me in the beginning that you are a very informal group, and I'm quite informal as well. So please interrupt me and discuss during the talk. You don't have to hold your questions, though you can as well. Okay, I will share my screen. Can someone tell me? I cannot see you. If you can just, you see my screen?
Yeah.
Perfect. And I think you do see my pointer, so I can use this to point.
Yes, you can.
Oh no, something. Is it okay still?
It's okay now.
Okay. So I couldn't understand the introduction, but by way of short introduction, and we were discussing before everyone joined, I am a cell therapist, a CAR T cell researcher here at Penn, but clinically, my specialty is transfusion medicine. So that involves dealing with the blood bank and helping with our apheresis clinic in the hospital. So, I have long been interested, given that background, in antibodies. And so the major focus of my lab is to mesh CAR T cells with problems created by antibodies or pathogenic antibodies. And so that's what I will talk to you about today. I will start with just a very short disclosure slide related to some of the things I'll mention today. And this is what I will talk about. Put the research in the context, the clinical context of pathogenic antibody immunity or humoral immunity. Why I think CAR T cells may be a good a therapeutic option in these settings where we're challenged. And then I will present some data trying to make the case that CAR T cells may actually be a useful solution to these problems. And I'll present both published data from our group as well as some very, very recent unpublished data mixed in. And the data will be from both humans as well as preclinical studies. So I know I probably don't need anything like this, but not knowing exactly the background, I like to start with my very simplistic view of the adaptive immune system. So here I just show some of the main players. In the middle is an antigen-presenting cell that first sees an antigen, a foreign antigen or a self-antigen, and then presents that to T cells. In addition, antigens can be recognized by B cells, the humoral side of immunity. And of course, as we know, there's a lot of crosstalk between the T cell arm of immunity, largely by virtue of CD4 helper T cells, helping the B cells. B cells then become activated and ultimately lead to the secretion of antibodies, which in most cases are protective antibodies. But in some cases, obviously, as we know, these can be pathogenic antibodies. And so we can classify pathogenic antibodies or pathogenic B cells in, roughly speaking, two categories: those that cause autoimmune disease, and I've listed many here that we're all very familiar with, especially this audience: TTP, being one, autoimmune hemolytic anemias, and other organ systems that can be affected. Some of, on the other hand, pathogenic antibodies can be directed against alloantigens, foreign antigens, and these can be against drugs. So again, this audience very well knows factor VIII inhibitors in the context of hemophilia, but also, if you will, a red blood cell in the context of transfusion medicine could be considered a drug. And of course, patients can mount antibodies against blood group antigens. Of course, this can also arise in the context of transplantation, either bone marrow or solid organ transplantation, either limiting a patient's ability to find a compatible graft or causing, after transplant, causing early premature graft rejection. So these are the things I have been interested in and applying CAR T cells. So the state of the art as we currently have it in terms of suppressing the antibody side of immunity or suppressing pathogenic or eliminating pathogenic humoral immunity consists of many of the agents I've shown here in red. So we have long had B-cell depletion in the form of monoclonal antibodies, namely rituximab, and now more recent later generations of anti-CD20. And so they work largely by depleting the B cells, including some memory B cells. But these are not perfect. We know from multiple reports that there are rituximab resistant B cell populations. Especially memory B cells, and they can be found in the spleen and maybe other locations, even though in the blood, the B cells are completely depleted. So these are not perfect. You all are well aware of immune tolerance induction as one mechanism of trying to suppress the pathway to antibody formation. This is also not a perfect avenue. Not all patients are candidates, very expensive, and relapses occur. It's not perfect. You can also inhibit downstream of the B cells at the level of the plasma cell, which is the cell that's actually secreting antibodies. This has been the bane of our field. Incredibly hard to delete these cells. So some of the agents, bortezomib has been tried, and we see case reports and case series pop up here and there showing efficacy in some indications, but there's probably a publication bias to that. And so it is, there's plenty of cases where this doesn't work. So we need something better to target these cells. And then there are certainly ways of getting rid of antibodies, and I've listed several here, including, I can't believe I haven't listed plasmapheresis, but these are all transient. They don't get to the root cause of the problem. So we certainly need something more to address these challenges. And so as I mentioned prior to the talk, I came to Penn about 11 years ago now. And around the time I arrived at Penn were some of the first reports of patients treated with CAR T cells at Penn who had achieved, after failing multiple rounds of chemotherapy for CLL, had achieved long-term cancer remissions. And this was quite impressive, and we and of course others were just starting to show this, and then we know the field just exploded for CAR T cells. But this is an example of one of those early patients that I saw where after 169 days after infusion, one dose of CAR T cells, the patient was in clinical cancer remission, complete remission. And as you can see, this patient had absolutely no B cells marked by CD19 and CD20, no B cells in the blood and no B cells in the bone marrow. So this was very impressive. And we had the opportunity to look at an unfortunate instance of another patient with follicular lymphoma who got one dose of CAR T cells and happened to succumb die at 200 plus days after that infusion of other causes. At the time of death, he was still in CR. So an autopsy was performed, and we looked at B cells by CD20, but also by CD19 staining in multiple lymphoid relevant tissue compartments, and found absolutely no B cells anywhere we looked. So this and other cases, and this has been published by us and others, showed us that these CAR T cells are remarkably efficient at going into tissues and deleting every last target cell as best as we can tell. So by now you all know that there are multiple CAR T cells that are approved for use in the US. There are now 4 different CAR T cells targeting CD19, the antigen on B cells. There's also recently one approved that targets BCMA, and I will talk about that. So the obvious question, even at a decade ago, was, can we use CAR T cells to overcome some of these limitations of humoral immunosuppression, where the therapies we have currently really don't fully eradicate the culprit B cells and plasma cells? So I'll just pause from that to mention the CAR T cell platform, which I don't need anymore because everyone is quite familiar with these receptors. But I would still like to make an additional point. So here I'm showing you the traditional CAR T cell, the construct. In a cartoon form, it is composed of an extracellular domain that is comprised of is basically an antigen binding portion that's comprised of the variable domains derived from antibodies. So this could recognize CD19 or any other target we choose. And that is linked as one protein, one gene, through a transmembrane domain through 2 intracellular signaling domains. And for different groups, use different signaling domains to elicit different T cell functions. So we can mix and match these signaling domains for whatever effector functions and so on we want from our T cells. And this, as you well know, is a very active area of research. What is the optimal signaling combination for whatever indication we are trying to treat? So these are termed first, second, and third generation CARs, depending on how many signaling domains are incorporated on the intracellular side to activate the T cells. So this can be expanded, and one of the very nice features, as you know, of T cells or CAR receptors is they are surprisingly modular. You can mix and match components, and they seem to still work beautifully. So this is just showing you mixing and matching different extracellular domains for different targeting goals. And I will highlight here, so you can use peptides or other antibodies mixed with proteins. Here's one that I will highlight that uses, and this is not something new, this was designed many years ago. It uses the portion of the IL-13 cytokine. The purpose for this was to target cells that express the IL-13 cytokine receptor, right? So this is, I believe this was, you know better than me, possibly. I think this was used for glioblastoma and currently still is in development for that indication. So we thought about this, and could we re-engineer this to target antigen-specific B cells? And so I will present to you a case of just that we have published several years ago as a proof of concept. So in this proof of concept, we decided to target this autoimmune disease, Pemphigus vulgaris. It's an autoimmune skin disease in which patients make autoantibodies against this protein, desmoglein 3, also called DSG3 for short. This is a protein that is expressed on keratinocytes. Shown here are 2 neighboring keratinocytes that attach to themselves, to each other rather, through desmosomes. Desmoglein is a major component of the desmosome that holds the keratinocytes together. When patients make antibodies, as shown here, it blocks this interaction, this homotypic interaction, and as a result, the adhesion between keratinocytes is affected, and they can form blisters. And here's an example of a patient with blisters that then ulcerate, and they can have serious infections. These patients respond very well to rituximab, to B-cell depleting antibody. However, the majority, something like 70% of them, will relapse. So long-term remission is not the norm. They will relapse, but they're treated typically again with rituximab, and they will again reach remission, which then lasts for another year, 2, 3 years, and then relapse again. And so it's repetitive treatment with rituximab. And in data that I don't have time to go into, we know from work done at Penn that the relapses are actually associated with reemergence of the same B-cell clones. If you sequence the antibodies, it's the exact same CDR3 sequences. Those signatures tell us that the same B-cell clones are coming back in the relapse, and that tells us that they were not completely eradicated the first time, because it's very unlikely that the exact same antibodies would be generated each time in a given patient. So again, in this case, rituximab works, but it doesn't probably do full depletion of the cells. So what we did was try to engineer CAR T cells to give us more stringent depletion. So what I'm showing you here on the left is the typical CAR against CD19, an example that we all know well, and it recognizes CD19, which is expressed on all B cells. It's a pan B cell marker. So it would delete, in theory, the autoimmune B cells in pemphigus, but it would also delete all the other protective B cells. What we thought was, could we change the extracellular domain and put the autoantigen, or at least domains of the autoantigen on the surface, to specifically recognize the B cells that have anti-desmoglein antibody on their surface? Selective depletion of the autoimmune cells. And so that's what we constructed. On the top here is a cartoon of the normal desmoglein 3 protein with different extracellular domains. So we constructed a number of CARs with different numbers of these extracellular domains, and then connected to the T cell activating domains that I mentioned. And so this is published work from 2016. So I'll just show a couple of figures to show you the proof of concept actually seems efficacious. Here is a mouse model where we engineered fake B cells to express the anti-desmoglein antibody on the surface and put them in mice in such a way that we could image the mice. And so in mice that have these target fake B cells with anti-desmoglein on their surface, without any CAR, with T cells with no CAR, non-transduced T cells or NTD, the cells will keep growing. It's basically a tumor cell line and will kill the mice in maybe about 2 to 3 weeks. CART19 is sort of a positive control. These cells also have CD19, so it will, as expected, will kill those target cells. And we found that the desmoglein, we call it a AA CAR for autoantibody or autoantigen receptor. But the CAA CAR will also effectively recognize those target cells and kill them. So we also tested it in a model of disease where we can put hybridoma cells that also not only express the antibodies on their surface, but will secrete soluble anti-desmoglein into the serum of the mice. And these antibodies, just like in patients, will bind to the keratinocytes and cause sloughing of the skin. And what we found is, if we put in the desmoglein 3 CAR T cells, and that's indicated in the red, and I have to just mention that I am colorblind, so sometimes if I mention a color, it may be quite off. I apologize for that. But here we're measuring the autoimmune antibody by ELISA, so serum anti-desmoglein, it should say, by ELISA. After 14 days after the infusion of CAR T cells, the antibody titers are quite low in these mice. However, in the control mice, the hybridomas keep proliferating and make more antibodies, so you see quite an increase in the antibody titer. And that, as I show you here, is associated with a difference in the binding to keratinocytes. So here are antibodies that are binding, whereas you don't have that in the CAR-treated mice, and the skin looks relatively intact compared to the non-CAR mice. So this was very promising and has now actually ultimately led to, last year, the opening of a clinical trial that's being run out of Penn that actually is using these CARs in first in human trial in patients with Pemphigus Vulgaris. So as you are probably aware, the same concept of trying to selectively target B cells is also being tried. So I just want to keep an eye on the time, is also being tried for other autoimmune or alloimmune diseases. This one you're probably well aware of, and I don't even need this slide, but can we use this concept to target inhibitor-specific B cells or factor VIII specific B cells in patients with hemophilia A and inhibitors? So again, another slide that I don't need for this audience, perhaps, but just a slide talking about the challenge, the clinical challenge of inhibitors in hemophilia A. So hemophilia A is this deficiency in factor VIII, where the best treatment is the replacement with either plasma-derived or recombinant factor VIII. However, in some patients, depending on their mutation, are at very high risk of developing alloantibodies against this foreign factor VIII protein, and that neutralizes its therapeutic function. And then they become very hard to manage. So there are ways to manage them, but these are not optimal. And I rely on my hematology colleagues, some of whom you know, such as Valder Aruda, a close collaborator of yours who I collaborate with here at CHOP, that these bypass agents are suboptimal. They're not as efficacious as if you could give actual factor VIII and have its own native function. Of course, the field has dramatically changed in the context of this novel antibody called emicizumab, which sort of, I guess, bypasses, it functions sort of as factor VIII by itself, bridging factor IX and factor X, supplanting the need for factor VIII. So this has been approved in the US for patients with inhibitors and has dramatically improved their lives such that they don't need factor VIII, they don't maybe need eradication. But I am told by my hematology colleagues that even in the context of this new drug, there are advantages for getting rid of inhibitors, especially perhaps in the context of breakthrough bleeds. Even in patients who have emicizumab on board, they would like to be able to treat with factor VIII. So, of course, there are other eradication methods, immune tolerance induction method, but this has its limitations. Gene therapy may be something that will eradicate inhibitors, and that's still to be determined. B-cell depletion in the form of rituximab has been tried with variable responses. So can we do something better with similar CAR T-cell? So there's been a report by another group. We are also working on this. We have chosen to, we started out by choosing immunodominant domains of factor VIII, namely the A2 domain of factor VIII, as well as the C2 domain of factor VIII. These are domains that most patients make antibodies against, inhibitors against. So we have grafted these domains onto CAR T cells and find that they function very well. I apologize to all of you right now at this juncture, just to say I'm not going to present our data on this. We have since incorporated basically almost all the domains of factor VIII and find that these CARs really function. We have gone through a lot of optimization and find that we can express almost all of the domains except for A1. There are major challenges with that. but I'm not going to present that data. I'm not yet allowed to present it, unfortunately. What I will show you is something that you may already be aware of from another group that showed, this was a couple of years ago in 2018 by David Scott and colleagues. What they showed with a CAR expressing the C2 domain or the A2 domain, that they could prevent inhibitor formation in hemophilia A mice. So if they dose the mice with the CAR T cells, they call them the BARs for B cell antigen receptor. If they dose the mice up front and then challenge the mice with factor VIII, they find that the mice that receive the CAR T cells, they do not make inhibitors or very weakly make inhibitors compared to control mice. So this is a prevention model. And I know that they've had difficulty, there's no report of, can these cells actually eradicate established inhibitors? And my guess is that's going to be a major challenge. And I will spend some time in the rest of my talk talking about that challenge. So I'll just stop here to see if you guys have any questions before I switch gears a little bit. Okay. So, this strategy is being developed for a number of diseases. I've mentioned to you now hemophilia, pemphigus. My lab is working on a similar concept for TTP, where you have a well-defined antigen, ADAMTS13. Others that would stand out to you might be neuromyelitis optica, where aquaporin 4 is a well-defined antigen. We think antibodies against that have a clear pathogenic role. Myasthenia gravis is another one. But, of course, there are a host of diseases where the autoantibody response is both pathogenic. We think that it's not just a bystander of the autoimmune reaction. The antibodies cause disease. But there are a number of antibodies targeting various different autoantigens all at the same time. So in that case, it's very hard to design one CAR T cell product to address all of those B cell specificities. So in that case, maybe there is still a role for non-specific B cell depletion. And so as Bruno and I were talking before my talk, this has already been investigated. So in 2019, there's this publication from this group who, as you would imagine, applied it to a murine model of lupus. So SLE or lupus, we know that there are multiple autoantigens that can be targeted. And for some time, there's been debate about which antibodies are actually pathogenic, or is it largely T cells that are pathogenic? I think we, by and large, can say there probably is a pathogenic role for antibodies, at least for affecting some organ systems, such as kidneys, due to deposition of immune complexes. So with that rationale in mind, with that idea in mind, this group tried to apply CART19 to target all B cells in 2 models of murine lupus. Excuse me. So these are 2, I'm not a lupus expert, but these are 2 lupus models that spontaneously develop lupus over time. So what they do is they give it time to develop, and then at a given time we'll give CAR T cells and then monitor for disease. And what they reported is actually quite nice depletion of autoimmune antibody. In this, I'm showing you anti-DNA antibody, which is obviously a well-known target in lupus. And what you can see is in the CAR-treated mice, shown in black, there's a significant reduction over time compared to non-CAR groups. In the bottom panels is there data on disease or survival of the mice in both of the lupus models, where you see that in those mice that had stringent long-term depletion of B cells, which is labeled CD19D, which is depleted, versus the CD19. So some of the mice, this is a little funny experiment where they gave the mice CAR T cells. Not all the mice achieved long-term B cell depletion. So they split those CAR-19 mice into two cohorts and called one just transiently depleted, or some term that is denoted by the S. And with very short-term depletion, they saw no survival benefit. But in those mice that had more prolonged depletion, there was a survival benefit. And in the other model, similar, the CAR showed a significant survival benefit compared to non-depleted mice. And so this was the impetus, or very much related to this recent report that we were discussing just maybe a month ago or so in New England Journal. It's a case report out of Germany, where they used the same CAR-19 targeting CD19 in a woman with refractory severe lupus. So she had multiple organ systems affected, I forget how long, probably years, and had failed multiple previous treatments, including chemotherapy, rituximab, and that's shown here. So they did leukapheresis, gave her CAR T cells, basically at the dose that is typically given in the dose range, about 1 million CAR T cells per kilogram after lymphodepletion chemotherapy. And then they followed her over time, only maintaining her on low-dose steroids. And so the data they presented obviously was quite dramatic. Here is the CAR T cells shown at day 7. They persisted for about 7 weeks. And, unlike treating cancer, for these indications, maybe we don't need long-term persistence. Maybe it's better to have actually short persistence so they're not long-term B-cell depleted. We can discuss that. So they achieved B-cell aplasia. And so that's shown here in this graph at the bottom, undetectable B-cells for several weeks. And accompanying that is this impressive data on her laboratory and clinical response. So the anti-double-stranded DNA antibodies, just like in those mice, declined and remained stable for this period of a few weeks. Her complement levels reemerged, so complement was not constantly being consumed, and her proteinuria also resolved. And so this is the SLE Disease Activity Index score, a standard scoring system, and that impressively reduced over time as well. So this is great if CAR-19 can work for more patients such as this. But I will go back to the experiment or the group that showed the preventative model in hemophilia with inhibitors. And I mentioned they were not able to show data on eradication. And I will bet anything that this targeting CAR-19 will not work for all pathogenic antibodies. So let me take a moment to talk about why I think that's the case. So I'll go back to an old paper, 2007, and this is sort of a landmark paper that's often cited that you might be familiar with. In this paper, they tracked antibodies, protective antibodies against measles, either infection-induced or vaccine-induced, or antibodies against tetanus, most likely vaccine-induced, in a cohort of healthy adults over time. And what they show here is the titer over age, and they tracked the same patients over, I think it was like multiple decades. This was an impressive study, and they look at the decay of those antibody response in individual patients denoted by these lines. Each color is an individual patient. And based on the trajectory, they calculate the half-life of each antibody response. And it's comical. You can see here for tetanus, the estimated half-life of that antibody response is about 11 years, about a decade. And so that's consistent with our idea of boosting with Tdap, tetanus every 10 years or so. for antibody responses to such things as measles, mumps, rubella, the half-life is 3,000 years. I mean, it's ridiculous. It's so stable that we don't have to boost against this. So how are these responses so stably induced? So we don't know for sure, but we are gaining quite a bit of insight over the last several years. But there are multiple theoretical mechanisms for how our immune systems maintain these antibody response. You'll, of course, remember that any given antibody protein doesn't last for years. It has a half-life of about 3 or 4 weeks, depending on what kind of antibody it is, IgG especially. So how can the response be maintained for years, maybe a lifetime of an individual? So on the bottom here, I'm showing you the progression of B cell maturation from its infancy in the bone marrow. When it comes out, it's a naive but mature B cell. And then after activation, it becomes a memory B cell, which then gives rise to plasma cells, which secrete antibodies. So memory B cells can themselves be long-lived and replenish their own compartment. And every time they get activated, they may make more plasma cells. However, the plasma cells themselves can be long-lived, we think, right? Theoretically, you can make long-lived plasma cells that will hang out for years, or some that are very short-lived, surviving for weeks, maybe months at most. And in the short-lived case, they may need to be replenished constantly from the memory compartment, or you can have both going on. And just to make it more complicated, in different disease situations, you can have different ways to maintain the immune response. And I'm not going to go into the detailed literature that supports the case, the statement that I make here, that some responses, we know now, we have very good data from mice, from now monkeys, and somewhat from humans, because it's hard to study, that some immune responses can indeed generate long-lived plasma cells. Going back for a second to that autoimmune disease Pemphigus vulgaris, where we think that just targeting CD19 will be useful. That's a condition like maybe lupus, where we think that long-lived plasma cells are in fact not generated. The patients respond to rituximab every time because the plasma cells, you delete just the B cells, the plasma cells, which are not deleted because they don't have CD20, those die off within weeks to months, and then the antibodies decay. The reason they relapse is because you've not deleted all the memory B cells, so they will come back after the rituximab is out of the system, and they will make new plasma cells. But in other contexts, yes, these plasma cells we think can last for years. And so we and others have shown recently that these long-lived plasma cells are likely in this fraction of plasma cells that are negative for CD19. So here's data from a healthy person. We took out the bone marrow, gated on plasma cells, and looked at CD19 expression. The majority of the plasma cells, about 70%, will express CD19, and then there's a minor fraction that is negative for CD19. And we think that this is enriched for the long-lived cells. So in support of that, we looked at patients who have been treated with CART19 and responded. They had no cancer, they're in remission, and the CART19 cells have persisted for years, and they have no B cells. And yet, in those patients, they have detectable plasma cells. If we look at those plasma cells, bona fide long-lived plasma cells, because they have no B cells to keep making new plasma cells, when we look at those, they're negative for CD19. Indeed, they're polyclonal plasma cells, not cancerous, and they make antibody spots. So they're really, truly functional plasma cells. So I'll go back to that autopsy case for a moment to show you. In this patient who died about 200 days after the infusion of CAR T cells, I told you that he had no B cells, again shown here by CD20. However, if we stain his tissue for kappa and lambda, we see in plenty of compartments, the bone marrow, and in the lymph node, here is in the lung, the hilar lymph nodes, as well as the lymphoid aggregates in the GI tract, where we know there are a lot of plasma cells. You see plenty of kappa and lambda cells. These could only be plasma cells. And by H&E, they look like very classic plasma cells. So this is a good indication, probably the best in humans, one of the best indication in humans that long-lived plasma cells can indeed exist that are independent of B-cell reconstitution. So I'll present one slide of unpublished data to tell you basically the obvious. In these CART19 patients who have long-term B-cell depletion, of course, as we expect, they cannot make new antibody responses. And so for the first time in my knowledge, we have shown that, and others have shown that as well recently, that to a new antigen, namely coronavirus, if they don't have B cells, they're still in a B-cell aplasia because of persistent CART19, we see no RBD-specific IgG responses compared to healthy patients who mount a very nice antibody response. Of course, there are some CART19 treated patients here I show you who did mount an antibody response. And these are the ones who have detectable B cells. So if the B cell count is very low or undetectable, they have negative antibody response. So that's obvious. They cannot make any new ones because they don't have the B cells to respond. However, we have shown, and this is just one case that really represents it nicely, we have shown in multiple patients, and now others have similarly shown it, that in these patients with prolonged B-cell aplasia, as shown in this graph here, for, in this case, 2 years, pre-existing antibodies are still retained. At least many of them are retained, likely due to the survival of these so-called long-lived plasma cells. So this is a case of a woman with lymphoma. I forget which kind. This is non-Hodgkin lymphoma, was treated with a dose of CART19, is still in remission for at least 2 years. That's the data time frame shown here. And we looked at these protective antibody responses against vaccines and pathogens, measles, mumps, everything very stable. She did have a decline in IgM eventually to undetectable, but she gets she doesn't get IVIG, I should say, but she has maintained her IgG levels, probably again from these long-lived plasma cells. This patient happened to have antibodies through prior pregnancy against HLA alleles, allo-HLA alleles, and those HLA-specific antibodies were also totally stable. So this is just one example. So in a situation like that, we really, I think, need to additionally target the long-lived plasma cells if we want to get rid of those types of pathogenic antibodies. As I've mentioned to you, they do not express CD20. That expression turns off much earlier in, just check the time, in B-cell development. CD19 also turns off somewhere during plasma cell development and seems to be negative on the long-lived cells. But there are antigens, as you well know, BCMA is one, that is currently being targeted in the context of multiple myeloma, and that also is on normal, non-cancerous plasma cells. So here is an example of a patient that was treated at Penn with the combination of CD19 and BCMA-targeted CAR T cells. This is bone marrow studied after 3 months following T-cell infusion. The patient's still in remission, MRD negative. As you can see, there are no CD19 positive cells. There are no CD138 positive plasma cells, which would include not only the myeloma cells, but also the normal physiologic plasma cells. Basically, no BCMA or CD19 positive cells are discovered. So, perhaps this is a good candidate. So we set out to model this in mice, and here is some in vivo data. I'm skipping a lot of in vitro, basically about two years worth of trying to make BCMA targeted CAR T cells from mouse BCMA, optimizing them and so on. It wasn't as trivial as I'd hoped, but what I'm showing you here is a mouse treated with non-CAR T cells versus CD19 CAR T cells or the combination, and gating on plasma cells by CD138 and this other cytokine receptor TACI. So you see this very clear population of bone marrow plasma cells. CD19 significantly reduces that population. As I told you, in humans, the same is true of mice. The majority of plasma cells do express CD19, but it's the negative cells that we think are the long-lived ones. When we add the BCMA-targeted CAR, we see a further reduction in that population. And so that's shown here for multiple mice, counting the bone marrow plasma cells as well as the splenic plasma cells. And so you can see this further reduction. Neither of these is statistically significant. I think there's a clear trend to reduction, but we would need more mice. Basically, the CART19 itself dramatically reduces the number of plasma cells to show an even further reduction from already reduced. Probably is hard for us to do. We just need a bigger N. And so that's just shown here graphically by ELISpot. The spot-forming plasma cells seem to be reduced. So, again, I'm skipping a lot of in vitro and in vivo optimization and jumping to a current experiment that's actually very fresh data. This is an ongoing experiment where we decided to apply this first to the context of transplantation, which I've mentioned to you. The case of alloantibodies against HLA or in mice against murine MHC. So these antibodies, as I mentioned, can either prohibit transplantation, finding a compatible organ because they will cause hyperacute rejection, or these types of antibodies after transplant will cause acute or chronic rejection. So in this model, we take a C57 Black 6 recipient mouse, and we put BALB/C skin graft, and it rejects over 1 to 2 weeks. Then we come in and put a second BALB/C skin graft to really rev up that immune response. That's very quickly rejected. Within a week, it's fully rejected, and the skin is mostly healing or healed. And then we will administer CAR T cells following irradiation as lymphodepletion. So the groups of the CAR T cells we have included in this type of experiment are non-CAR T cells targeting only CD19 or CD19 plus targeting BCMA. I didn't have time to show you, but I'll just say we have also found in vitro, we've made CARs targeting murine CD38. You're familiar with this this antigen, daratumumab is a monoclonal antibody that's being used for multiple myeloma to target CD38. There have been reports even in the Hemophilia A literature of daratumumab getting rid of inhibitors in small numbers of patients recently. So we found that we can deplete plasma cells, mouse plasma cells in vitro, so we also tested in vivo as a separate group. And then we followed these mice over time to check their antibody titer by flow cross-match and by ELISA. There's a note here that we give these mice gamma secretase inhibitor. I don't have time to go into the details, but you may be aware, but BCMA is an antigen that can be shed or cleaved from the surface of the cell by this gamma secretase enzyme complex, and that's lost from the target cells. So we have to give an inhibitor to increase the expression on the plasma cells, and that's also being tested for multiple myeloma in clinical trials. So here's the data. So this is data looking at the antibodies after CAR treatment in the mice by flow cross-match. I'm not sure if people are familiar with this test. It's also used by the clinical lab that supports your transplant programs. Basically, they take the serum from the recipient that has the antibodies, and they mix it with lymphocytes of the donor. And they then do flow to see how many antibodies are bound to the donor. Presumably, those antibodies are mostly binding class 1 and class 2 MHC or HLA in the clinical setting. So here we take the serum from our Black 6 mice, mix them with the donor splenocytes, BALB/C, and then we stain with anti-kappa to measure to detect any Black 6 antibodies bound to the donor splenocytes. Here are the non-transduced control mice. Here are the CART19. Each box is a representative mouse out of about 7 mice per group. And on the x-axis is the mean fluorescence intensity, or the MFI, of the antibody level over time. So here's a non-sensitized mouse as a control. No antibodies, it's low. At baseline, that means the baseline right before CAR T-cell infusion. Already they've received 2 skin transplants, rejected them, so they have a high level of antibody. And as you can see, over a course of 10 weeks, there's no change. There's really minimal to no change in the level of that antibody. However, in the mice receiving the combo CAR T cells, both BCMA or CD38, you see this nice shift. And in some mice, it basically looks like a non-sensitized mouse after 10 weeks. So that data is shown here, including all of the mice, over time, from baseline to week 10, looking at that same, by the same flow cross-match assay, you can see these 2 groups slowly trend down, whereas the non-CAR T cells and also the CD19, there's really no change. We also show the same decline by an orthologous assay, which is ELISA. We coat the ELISA wells with the allo antigen. In this case, it's the MHC class 1 from BALB-C, and we can detect antibodies. There's no change compared to baseline. This is normalized to baseline. There's really no change in the control group or the CART19, whereas there's a almost total decline in the combo T cells. So if we look at total immunoglobulins, total IgG, in the control mice, there's no change. We're not targeting any B cells. In the CART19 group, there is actually a reduction in IgG. And maybe that's not so surprising because we have taken out all the B cells and most of the plasma cells. So we're just left with those long-lived cells. So we might expect this. We also see that decline as we would expect when we add other CARs to the CART19. There is now starting to be a reconstitution of the IgG. And despite the increase, the reconstitution at week 8, we still see no alloantibodies, which suggests to us that we have really stringently depleted those plasma cells. Sorry, I don't have too many more slides. This is just a graph looking at the actual B cells in the blood. In the control mice, after the lymphodepletion, there is a decline, but then they reconstitute very quickly their B cells. CART19, the B cells are gone. The other 2 groups, they are gone, but then it's transient. They are starting to come back up. And this slow reconstitution is likely explaining the reemergence of total IgG. However, even in that setting, the alloantibodies are not coming back. So what did we do next? Can we functionally test this? Is it really a truly stringent depletion of that alloantibody response? So this is what we did. We induced diabetes in these mice with streptozotocin. That's a chemotherapy agent that you probably are familiar with in the context of pancreatic cancers, I think. It's toxic to the beta islet cells in the pancreas, and it will induce diabetes. Following the streptozotocin, we check the blood glucose to confirm diabetes. And then we will use ATG, anti-thymocyte globulin, to suppress the T cell response because the CAR T cells are not addressing T cell alloimmunity. So we give ATG, and then we transplant islet cells from the same BALB-C donor, the same donor as those 2 previous skin grafts. And then we monitor blood glucose to look at the graft survival. And so this is, I'm not kidding, this is an ongoing experiment where we're measuring, even today, the blood glucose. So I'm going to show you this graph, this chart, which is very busy, but it makes the point, I think, very beautifully. This is blood glucose measurements every day, with day 0 being the time of the islet cell transplant. Here are the same groups I've shown you before, the combo groups, and here are the actual blood glucose levels in the 300 to 500, 400 range, and that's shown in red. If they're in the 200 range, then I think this is green, and you can see that either in both of these groups, there is either there's a lack of primary engraftment, or it rejects very quickly. And so most of these mice in these group have already rejected. There are some that still have at week 7 or day 7 have a functional graft. We need to do more studies, take them out longer and see what happens. But at this time point, there's a stark difference. These mice seem to be having functional grafts. Okay, so I'm near the end, and I've told you that we have now targeted a large component of the humoral response. We think we can target B cells stringently and maybe have tools to target these long-lived plasma cells. It took us about 13 weeks to feel comfortable that the MHC antibodies were depleted before we did the islet cell transplant. So that's a long time. In patients, it would be even longer because antibodies have a long half-life. In mice, it's a week. In humans, it's 3 to 4 weeks. So can we actually hasten this process? Can we also address this part, completely addressing humoral immunity? So one obvious thing is you can use plasmapheresis to quickly deplete the antibodies. In the mice, we cannot do that. So our next experiments currently running is to try and deplete the antibodies by targeting the neonatal Fc receptor. So the neonatal Fc receptor is a specialized receptor for antibodies, and one of its major functions in an adult is to recycle antibodies that are taken up by endocytosis by cells like the endothelium, so that the antibodies bind to this Fc receptor and they are trafficked away from degradation back into an exocytic pathway, so they're returned to circulation. So it's really important for maintaining the half-life of antibodies. So we are collaborating with Sally Ward in the UK, who has spent her career, a large part of her career, engineering therapeutics that compete with binding to FcRn to enhance the turnover of endogenous antibodies. And she calls them ABDEGs, so antibodies that enhance degradation, I guess. And so here's a picture from her group showing infusion. 1 dose of this ABDEG dramatically decreases antibodies. So this is what we are currently doing, is to do the same transplant, give our CAR T cells, and then give doses of ABDEG to enhance the depletion of antibodies. So that is ongoing. I will stop there and just summarize. These are the points that I've talked to you about. I'm happy to discuss them as time permits. I've made the case, hopefully, that humoral immunosuppression, we have many tools currently, but they all have serious limitations. CAR T cells are highly effective cells at seeking out their targets, and they may be a good answer to this problem of humoral immunosuppression. We may have fancy CAR T cells to be very specific and selective to leave the protective arm of humoral immunity intact, but in some cases we may not be able to do that, and we may have to do a pan B cell or even a pan plasma cell targeting approach. And in that case, it may have to be engineered to be transient, so the host can, after we have depletion of the pathogenic cells, they can reconstitute their humoral system. I have not gone into it, but many limitations of these CAR T cells systems or platforms remain to be addressed. We will only address some of them in human trials, which are just starting. And so following the mouse studies that I just showed you, we are actually recently funded by the NIH here to test the combination of the very same CARs I told you in patients who are listed for a kidney transplant but cannot be transplanted because they are very highly allosensitized, sensitized to 99.9 to 100% of the donor population. So that work will start hopefully soon. And with that, I will stop and acknowledge a number of groups, a number of people at Penn and CHOP who have worked with my lab. In my lab, I would highlight a postdoc who is doing a lot of the transplant CAR T cell studies. I would also like to highlight Dr. Ali Naji from surgery. We're collaborating with on both the preclinical and now the clinical studies of CAR T cells for transplant rejection. I will stop there. hopefully I didn't go way over your time, and I will let you ask questions.
Well, thank you very much, Vijay. It was great. I'm very, very surprised. Congratulations for your new founded project, because it's really promising. I think, Bruno, you want to start? Raise your hand.
Yes. Vijay, thank you very much for your lecture. These are great and exciting results. From what you showed us, I'd like to make you two questions. The first one is, how do you see, how will you reconcile the CD19 and BCMA effects on autoimmune disease? From what I understand, you told us that there are not all autoimmune diseases that demand the eradication of this long persistence, long circulating plasma cells. So for some diseases, only CD19 depletion may be enough. For other diseases, BCMA seem to be necessary. Do you think we'll have individualized approaches for each autoimmune disease, or a single approach for everyone? And in this same sense, how do you see the persistence of these CAR T cells in each scenario? I mean, you could infuse a short-living CD19 with a long-living CD-BCMA, or
Sure.
The other way around. How do you see all of these combinations?
No, great questions, Bruno. So, very hard question, the first one, because I don't think we know, but I can talk more about that. So, the immune response to an autoimmune antigen, as you can imagine, is very different from an alloimmune response, where in one situation, the antigen is constantly there, it's constantly provided. And so it may send B cells down a different activation and plasma cell developmental pathway. But it's more nuanced than that. So the data that's supported for pemphigus, and I think many of you will agree with me, that also support for TTP in many patients, that just targeting the B cells may be sufficient, is because in both contexts, many patients respond really nicely to rituximab, right? And so that tells us that probably the plasma cells are decaying and they're not long-lived. But you guys probably know well that not every TTP patient even responds well to rituximab, right? So maybe even within a disease, there's heterogeneity where, for whatever reason, one patient may lead to production of long-lived plasma cells where they need additional therapies. They're refractory. We have, and then going broader from that, myasthenia, or the first thing that comes to mind, we published, I think it's published now, it's just a case report of a patient with an autoimmune kidney disease targeting PLA2R receptor. And that patient had rituximab, had various B cell, therapies that should target B cells, but had refractory disease. We gave bortezomib and responded beautifully. So I think it's going to be heterogeneous, and I can't explain why. I think that's a big question that people doing very basic work on plasma cell, the early stage of B cell to plasma cell transition, looking at that transition and finding out what are the signals that send it down a long-lived versus short-lived pathway. I think those are still really important unanswered questions. I will say that what I've been trying to do for a number of years, which has not been easy, is to use the CART patients, the cancer CART patients, as tools to study basic biology of long-lived plasma cells. They are the best source, in my opinion, of long-lived, bona fide, functionally defined long-lived plasma cells in humans. Can we take out their plasma cells and characterize them, their transcription, epigenetic profile, and get the signature, and use that to look at the early immune response in normal patients to vaccine and see, which cells match that signature? These are some of the things we're thinking about. Your second question was about persistence, which is a good question. I would say, at least for now, people would be very afraid to have in autoimmune patients or transplant patients who don't have the same risk-benefit calculus as an advanced cancer patient to to subject them to potentially lifelong B-cell aplasia. So probably if we can eradicate the antibodies and we think the eradication is deep, then I would like to get rid of those, either by, ATG, non-specific methods, or by suicide genes. But in the case of like that desmoglein or the factor VIII specific, those should stay forever if we can. I don't know if I answered that adequately.
No, you did. You sure did. It's very interesting because as you mentioned, and each disease has its own behavior, and you talked about TTP, and we are currently with a patient with TTP in our inpatient unit, and we will discuss this case later. And what we see is we did rituximab, and the patient is responded very slowly, and we were considering doing bortezomib, but now the patient is recovering. So
responded. Yeah, I will say, if I can just add, I don't mean to manipulate all the time for this question, but in the trial that we plan for a transplant, we do not plan any specific suicide mechanism. If they were to go to transplant, they will get the standard ATG. No one has shown that will be effective at depleting CAR T cells, but we believe they probably will. But in those patients that we're selecting for the trial, they have such a bad prognosis. They've been waiting for a transplant, in some cases, for 10 years. Their morbidity and mortality approaches that of myeloma patients. So the calculation may be more favorable to to take the risk of long-term immunosuppression.
Okay. And the second question, and don't get me wrong, but when we were discussing with the fellows your presentation today, I think someone said, but isn't it too much CAR T cells for autoimmune diseases? So I don't mean to offend, but I would like to give you the chance to defend your point, which was very well presented here.
I struggle with that too, and I agree with your fellows in some situations. Again, it's a risk-benefit calculation, right? I think for the majority of patients, if they respond to monoclonals, that's great. But some will not. And the morbidity associated with some of these autoimmune diseases is quite vast. So maybe we're not there. That's your, subject to everyone's opinion. But for TTP, we are seeing more data that there are long-term consequences. You know this data probably from Jim George and others, that even in the absence of acute presentations, they might be suffering significantly over the course. So there may be benefit to truly getting rid of the antibody levels, not just preventing acute flares of presentation. I had another thought. Of course, some of these can be seen as proof of concept. The field of immunotherapy is also, engaging T cells through bispecific T cell engagers or BiTEs. Mm-hmm. That might be the way to go.
Approach, right?
Absolutely.
Another question? So Vijay, I have a question in terms of actually going through what you discussed with Bruno. In terms of how to choose the best candidates that will benefit from the CAR T approach. So you showed two ways. One is the concept with Pemphigus, that there is an antibody that is directed to a specific antigen. But in lupus, for example, we know that the antigen can be several different antibodies that can determine the disease in several organs. So when you think to design a specific CAR T approach for autoimmune disease, how you think is the best way to go, and who will have the best results? In terms of this one that you can target a specific one, and also this long lasting effect, or as lupus, a specific case as this very terrible one that you can have like more different antigens that is involved.
Yeah, that's a good question, and the decision may be made for us already, and maybe something I alluded to, but maybe glossed over. But you also said it. you cannot make that CAR T-cell platform in a reasonable fashion, I think, for so many epitopes, so many target antigens, and it just becomes cost prohibitive, logistically prohibitive. On the other hand, in those patients, if the biology catches up and we know that, despite having so many autoantibodies, these are the ones that are truly pathogenic and they are a small subset, that may guide us. The other issue is not only the number of antigens, but can we, and I think this is a big issue, can we recapitulate on a CAR the epitopes that are targeted by the antibodies? So for example, in the case of NMO, it's a discrete target, aquaporin 4, at least I think that's one of the major targets. But the epitopes that have been described that are recognized by antibodies in patients, they recognize epitopes that are very conformational and span multiple loops of this membrane protein, this channel, water channel. It's hard to reconstruct those epitopes in a CAR molecule. People are trying to do that, but I think, that's also going to make us decide, we just cannot make such specialized T cells. It's worth doing the pan CD19.
Yeah. Any other question? But I hope you know the approach, because you talk a lot about these long-lived plasma cells. Of course, this is undesirable for autoimmune disease, but for vaccines, this can be great. If you can mobilize these long-lived plasma cells for some of the vaccines, COVID-19, I guess. The people are looking for that. Do you know? You told about some possible approach for that. Do you know how far they are looking for this particular possible population of cells?
That is one of my interests. I haven't seen anything yet. And I haven't heard of people's, I'm sure people are looking for, does the vaccine induce this population? It's just a matter of time. We have to be more time since the vaccine, or use the method that I mentioned, is to find their signatures, validate those signatures in other immune responses, and see if those signatures are recapitulated in natural infection with COVID or vaccination. But short answer is I haven't heard of anyone specifically looking at that, but we're planning to.
Okay. Any other question?
I'll just say, sorry to interrupt someone, but these plasma cells have, the biology has really lagged because they're very hard cells to study. There are very few in the body. They're not in the blood by and large. They're in the bone marrow, the spleen, the gut. They're in these other tissue compartments. And although ironically, they live for a long time in vivo, you take them out, they're very finicky. They will die within hours. You cannot do that much that easily with them. So it's really hampered some of the biology. Yeah, sorry, I interrupted someone.
No, I'm just asking if anyone else has a question. Well, Vijay, I think it was fantastic, outstanding presentation. I'm very impressed with your work, and I'm sure everyone really appreciates your time that you spent with us today.
Thank you again for the invitation. I'm really sad I couldn't meet people and chat about what you're doing and possible intersections. I'll probably shoot you some emails about TTP. I'm interested to see if you do any biobanking where we could collaborate, things like that. So